Hello, good evening, everybody. Thank you all for joining us today for this webinar. Today, we are going to be looking at the knees, assessment and management of the knee. So we have got Ian Edwards, an extended scope physiotherapist, who is going to be leading some presentation. And we've also got Mr. Parker, a orthopedic consultant, who would be also coming on the call to talk about referrals and also answering some questions as well. Please feel free to turn off your video as well as put yourself on mute so we can just hear Ian clearly. Also, if you got any questions, please feel free to put it on the chat box and we will be going through that at the end of the presentation. Thank you so much. Over to you, Ian.
Hi there, thanks a lot for that. So my name's Ian Edwards. I am part of the musculoskeletal team. I'm currently based at Porters Avenue Health Centre. I've been previously at Vicarage Fields and also at Thames View. I've been posting out for 15 years. I'm not a specific knee specialist. As an MSK at Porters Avenue, we see all aspects from necks, backs, knees to feet. Regards to the presentation today, I wasn't quite sure what people would like to see. Just going to try and, so the plan for the session will be to start by maybe looking at more the subjective history. I think it's an area that we often miss. Lots of the knee presentations I've been on has been very much based around orthopedic testing for knees, ACLs and meniscal work. I'm also aware of our audience. We've got a combination of physios, FCPs, ESPs, GPs. So I've tried to make it a bit more generalised rather than being just physiotherapy specific. We're also going to touch on some biopsychosocial considerations for knee pain. Again, it's an area that is often talked about with back pain, but less regularly with knee symptoms. We're then going to go over some of the more serious stuff, so look at some of the red flags. We can then look at what investigations to do and when, and then finish with some questions. I'm not sure how long this presentation would take. It'll probably take 20 minutes to half an hour, so there will be a chance for questions at the end. We're also lucky to have Mr. Parker here, who's an orthopedic knee specialist consultant at King George, and he'll be available at the end also to discuss and hopefully say hello and just give us some further information. So in regard to the subjective, I think it's important that we listen to our patients. They're likely to tell us what we need to know. I think this is really vital. I think if we can take the time to listen and to listen to what they're saying to us, it's going to make our objective examination much easier. I know there's time constraints, we don't have long sometimes, but having the ability just to stop and listen to them is going to make things much easier moving forwards. So I've just started with some of the important aspects to include when taking history. The first, it seems quite obvious, it's trauma versus non-traumatic. Now, when we're considering knee pathology, I think it's vital that we find out the full history. So for example, if someone had severe pain post-trauma, it would suggest and make us think that it could be one possibility. Or if someone had non-traumatic knee pain, but swelling, it might make us think of another pathology. So we'll touch on trauma a bit in the next slide, but I think it's really vital that we get a good history and work out, has any trauma been involved? Secondly, whether it's one knee or both knees. Again, if it's bilateral knee pain, it's very much likely for us to consider one group of symptoms and pathology. For example, the classic would be bilateral patellofemoral knee pain. It's very unlikely to have bilateral non-traumatic meniscal tear. So for us to work out whether it's one knee or both knee is really vital. The next is how long have they had this issue for? So chronic problems versus acute problems. If someone had a severe onset of acute pain that only lasted a couple of days, that would make us consider maybe that there was something more serious going on compared to more chronic problems. Long-term issues aren't always not serious, but again, it might make us think that this is a different pathology that we're looking on. I think it's also important to look at the onset of trauma to pain. For example, if someone fractures their leg or ruptures their ACL, normally it's a sudden onset of pain. pain that delayed post-trauma it's not like to be a fracture or a more serious pathology. Again, it's important to look at the location, and patients can be quite hard to tie down, but it's important to look at the knee during the subjective and work out where that pain is. Generalized knee pain that involves the whole knee would be different to a person that is very specific to location. So if someone had very specific traumatic knee pain on their MCL or around their cartilage and joint line on one side, it might lead us down one path, whereas a patient with generalized knee pain would make us think that this is maybe a different source of symptoms. It's also important to consider the severity of the pain and also whether it's mechanical or non-mechanical. So most knee symptoms will be mechanical. We'd expect them to have pain during certain activities. Now, we often relate these to more aggravating and relieving factors. For example, the classic patient with patellofemoral knee pain might have discomfort on squatting, up and down stairs, whereas someone with more meniscal signs might have pain when twisting. Pain, hopefully, should be mechanical. There should be clear aggravating and easing factors. And when we come along non-mechanical pain, that can make us consider other factors such as tumours, infections, and arthritis. And again, we'll talk about those a bit later on during our section on red flags. We talked about aggravating and easing factors, so it's important that we look at those. And again, it's thinking about the presence of non-mechanical pain. So we just touched on those three, being tumours, inflammatory arthritis, or severe osteoarthritis. Also, lots of patients have had previous surgeries, previous injuries. It's really good to find out what's been done, and particularly if they've had surgery in the past. Is this a recurrence of an old injury? There's other medical problems in the knee. There could be gout, it could be some form of inflammatory arthritis. So have they had those issues in the past? What's in their medical history that can help us? The last few points there are locking, giving way, crepitus and popping. So these are descriptions patients often give. Again, locking when the knee completely locks can be a sign of a meniscal injury. Giving way could be a sign of maybe muscle weakness or tendon rupture or ligament disruption. Crepitus is often associated with an arthritic knee, and a popping sensation described by a patient could mean that there's been some disruption to the ligamentous system. So this section just looks at trauma. So if we're thinking trauma, obviously we're thinking more fracture, ligament injury, cartilage damage, possible muscular rupture. It could be just a soft tissue injury or maybe a patellar dislocation. When we're looking at injury, it's important that we find out the mechanism of injury. So has there been direct trauma to the knee? Has there been a twisting injury? Twisting injuries are often associated with ligamentous and meniscal injury. Acceleration and deceleration again, particularly in sporting environments. It's classic for footballers and rugby players to have meniscal and cruciate ligament injury through periods of extreme acceleration or deceleration. Speed of symptoms develop. So is it delayed? Again, if we're thinking fracture, we're thinking immediate. If we're thinking more soft tissue, we're thinking delayed. Cartilage problems can be both. Ligamentous issues, when severe, when they're ruptured, are normally very painful straight away. So we're expecting more immediate signs. Delay in pain might suggest that we're not dealing with such a serious injury, whereas the more serious stuff tends to be immediate. Swelling, again, can be rapid or delayed. And again, it can give us an indication of the severity of problems. Bruising is always interesting. Obviously, bruising is bleeding. What bleeds? Well, muscle can bleed. So the classic would be a muscle tear or a tendon rupture. We get a lot of bleeding. We also see bruising sometimes with ligamentous injuries. When we do get problems with the ligaments, it can give way. And again, we talked about popping and tearing sensation. So with trauma, it's clearing out some of those bigger factors such as fractures and ligamentous injuries and cartilage damage. There's also loads of other reasons why we get knee pain. So it isn't just trauma. There's just a list here of things like infection, tumours, patellofemoral pain. Pain can be referred from the hip and the knee. It could be arthritis, inflammatory arthritis, Osgood's and Cindy Larson, Johansson, which are much more associated with adolescence. the sciatus, gout, muscular pain, groin pain, degenerative meniscal tear. So there's a huge group of possible pathologies, possible source of symptoms. And through the subjective examination, we're trying to get to the bottom of what's going on. It's also important to think about other joints. So as well as the knee, other structures can refer into the knee. So there's 4 here. So we've got hip, lumbar spine, neurogenic referred pain, or the muscular system around the knee. So for all these problems, when it comes to examination, it's important that we discuss them in a subjective point of view, and also they can be used to help with our hypothesis generation. So we can test the hip, we can test the lumbar spine, we can move them into positions that may reproduce that patient's symptoms. So the classic example would be someone with a severe hip OA and the patient is describing it as pain in their knee. When we assess the hip and we push them into flexion or do a quadrant test, and it reproduces their knee pain, then we know it's coming from the hip. Likewise, if we move them into lumbar extension or flexion and it brings on their knee pain, it could be linked from the lumbar spine. We know nerves can refer down the leg, so nerve sensitivity can be an issue and can refer around the knee. Also, other muscles around the knee can affect. So I had a patient in last week who was a physio. She had knee pain. She'd been assessed by people at work and she couldn't work out what was wrong. And when we tested her, when we squatted her, rotated her, did all the orthopedic testing, everything was fine. The moment we put her into a modified Thomas test, which looks at sort of muscle length around the hip flexor and the ITB, it brought on her symptoms straight away. So we know that the ITB and other muscles around it can affect the knee and create pain. So it's always important that we look at other hips and other structures around the knee. So when it comes to making decisions in MSK, there's some basic principles. So if we always think joint, muscle, vascular, neurological, and biopsychosocial, we're going to cover most of those areas. So obviously with the knee, we need to think tibiofemoral joint, patellofemoral joint, and tibiofibular joints. Also thinking about meniscus, ligament, articular surfaces, and bursa. We think about muscles, whether that's bruising, a strain, a tear, a rupture. Is it weakness or is it tightness? It's always best to clear vascular signs. So obviously around the knee, we'd be concerned with any signs of a DVT. From a nerve point of view, we can clear it from a neurological point of view. And also there's biopsychosocial considerations. Now, I think when we consider this area, it's probably one of the areas that we can spend least of our time looking at. But as research develops, we know it's becoming one of the most important areas. When we look at biopsychosocial model of care, we're not just looking at structure, we're looking at other factors that can influence the patient, influence pain, influence tissue sensitivity. So we know things like age and gender and genetics are all biological factors and tissue health that can affect a knee. But there's other factors such as mental health, emotional health, beliefs and expectations, social support, social economics. All these factors can influence the way that we deal with pain and the way that our body perceives pain. And I suppose this area got me thinking slightly. If you go onto Twitter and you look at all the current research that's out there, or you go online, there's so much more information now about the way that we manage knees in a different way. And there's quite a lot of information, there's quite a lot of research going into osteoarthritis. So knee arthritis is widely understood to imply that symptoms are due to structural damage. And this leads to this belief by many people that non-surgical approaches they don't always work. Whereas the current research tells us that things such as inflammatory processes and tissue sensitivity and behavioural responses that lead to pain and disability can all be affected by biopsychosocial factors. Peter O'Sullivan has done lots of work on the lumbar spine, has done quite a lot of research into the knee, and he's found that by influencing factors such as patient's belief, expectation, fears, anxiety, that we can lead to a reduction in knee pain and improve knee health. There's quite an interesting wave of thought going on around this concept of wear and tear. I think it's a terminology that we all often use. And rather than saying wear and tear, I think a better way of looking at it should be wear and repair. Patients' beliefs are huge. If a patient believes that they've got severe arthritis of their knee or they've got a degenerative meniscal tear and they're going to avoid loading, they're going to avoid exercise, they're going to not bend their knee, then that will lead to a poor health outcome. We know that knee pain is complex, and we've already said that there are many factors that can contribute. I think it's important to remember that we are bioplastic, we are changeable. And maybe we need to get patients thinking more about wear and repair and exercise and movement rather than avoiding and fear and all the things that we know that can increase pain and increase tissue sensitivity. So with arthritis in mind of the knee, there's probably three big areas. First is increasing knowledge. And this is why education is so important. So I think sometimes it can be very easy to read off an MRI scan or read off an X-ray, and the patient goes away with fear and anxiety around their condition, whereas what we should be doing is telling patients that, look, you do have these degenerative changes, but by being active, by exercising, that it can lead to better health of those structures, and also it can lead to better health from them as an individual. We know now there's loads of research about increasing activity is important. And also, if we can reduce inflammation around the joint, whether that's from pharmacological interventions or by reducing tissue sensitivity in other ways in physiotherapy, then we know that that will encourage good cartilage health and good knee health. There was a really interesting article recently that looked at marathon runners, and I think if someone said to you, if someone had a knee problem, should they run marathons? And I think in the past, we always had this fear of exercising, but there was a really interesting study recently by Holger in 2019, and he took a population of asymptomatic runners, and he made them train to run a marathon and compete in the marathon. He MRI scanned them before and after, and what he found is that there was improvements in the health of the subchondral bone on the tibial and femoral condyles on MRI imaging after they completed their marathon training. So what the current research is telling us is actually by loading your joints, by exercising, that it will improve the health of your knees, and we should be encouraging people to move and remain as active as possible. Also really interesting that when they scanned these people before they started to run, they found loads of people that had meniscal tears that were completely asymptomatic, no pain. When they ran and did the marathon training and they re-scanned them, these tears hadn't deteriorated at all. So there's lots of research out there now encouraging people to remain active with knee pain, particularly in arthritis. Now, you know, if we had a 30-year-old with a sudden onset locking knee and meniscal tear, that's a different group. That's going to be the group that will probably need an arthroscopy. But for the general arthritis group, it's very much more aimed towards keeping people moving and keeping people active. And also, when we diagnose arthritis, when we tell that patient this is what you have, we also notice that other things deteriorate. There's more depression in people. There's an increase in cardiovascular disease, increase in back pain, diabetes, and osteoporosis. So by giving this diagnosis, we need to be aware that it can affect other factors, and by keeping them active and fit, it is going to also improve their general health. There's a few links on there. I know this is being filmed, so there's a few really good links on there to arthritis and keeping people moving, keeping people active. So the next section is really going to be looking at pathways and in particular at red flags. So for all knee issues, there's pathways. And when you look at a pathway, there's always this section in red, which is more red flags. Red flags for the knee, I'm going to look at 5 main areas. So we're going to look at infection, tumour, inflammatory arthritis, fracture and tendon rupture. So infection, there's 2 main types. There's septic arthritis, which is infection of the joint, of the knee joint, and osteomyelitis, which is infection of the bone. It's a bacterial infection. It's associated with redness, heat, swelling, and severe pain. It's often a rapid onset. It's non-mechanical. It's normally one joint. It can be more than one joint. A fever can be present. The patient often feels unwell. There's big risk factors with this: post-surgical, post-injections, post-prosthetic joints, also linked with intravenous drug use, and people that have ulcers or skin infections around their knee. If we're picking up these patients, they need to go immediately to A&E emergency services. They will have blood test screen, they often have joint aspiration, and this will be taken to a lab for investigations. Sometimes once there, they will have an X-ray, a possible MRI scan. Normally they're treated with antibiotics and a joint aspiration. The second big group that we're looking out for is the possible tumour or bone or soft tissue sarcoma group. Again, this pain is often persistent, it's non-mechanical, there's no history of injury or trauma normally. It often is associated with nighttime pain. Sometimes patients have a weight loss, they may have a previous history of cancer. Sometimes there could be hard swelling, mass or lump around their knee or anywhere else in the lower limb. And sometimes they're feeling just generally unwell. Again, they need urgent care. So we're looking for these to go to the urgent 2-week pathway. NICE guidelines suggest that it should be an X-ray for a bone sarcoma, an ultrasound for a soft tissue sarcoma. Once under a specialist, however, they often have an MRI or a CT scan. They also have their bloods reviewed. So I suppose for those two groups, they are unusual, but we do pick them up in a GP, ESP and FCP setting, and there's things for us to be looking out for. Inflammatory arthritis, this is another group that we do see, the most common being rheumatoid arthritis. For this group, it's pain, swelling in the knee. For them, it's often worse on rest or inactivity. They often describe morning stiffness. Sometimes they can have other joints affected, the classic being into your hands and feet. There may be a history of psoriasis in the hair or on the body. They could have had a recent infection. When we're looking at tendinopathies, this group often, who have inflammatory arthritis, also often have things like an Achilles tendinopathy or lateral epicondylitis of the elbow. So it's looking for this pattern of morning pain, hands and feet, other issues, tendinopathies and psoriasis. Now for management, they often go to rheumatology. We're looking at blood testing, so we're looking at rheumatoid factor, anti-CCB, full blood count and our inflammatory markers. Often we also can X-ray the hands and feet. There is a urgent pathway which patients can go onto. In our trust here, we have this urgent early arthritis referral form with patients' details. You can put onto it with what joints are affected, and also, and this gets referred onto rheumatology. It's trying to pick up people that have it very early so we can get them onto medication and treatment straight away. There's a few tick boxes here, so it'll be swelling to more than 2 joints, positive squeeze test, which is where they squeeze the hand into the hands and feet. If patients had any of these symptoms with morning pain and we thought it was inflammatory, then they can go on urgently to rheumatology. Fracture, as we said earlier, is sudden onset, it's traumatic. We need to consider other factors such as past medical history of fractures, cancers and osteoporosis. When it comes to X-raying, it's the first step. There's the NICE guidelines would suggest the Ottawa rules, which is an inability for a patient to walk or transfer over 4 steps. They can't flex their knee beyond 90 degrees. If there was tenderness in the head fibula, if there was tenderness of the patella over 55. So any of these symptoms we think in X-ray. If we think someone has a fracture, then obviously an X-ray would be the first choice, or we can send them straight onto A&E to have that investigated. For a tendon rupture, again, uncommon, but we do see them. It's often associated with severe pain or a popping sensation. It can be via trauma or sudden eccentric muscle loading. With this, we often get a massive amount of bruising, there's deformity into the hamstring or the quadricep. The leg can give way, patients unable to extend their knee, or inability to weight bear. So for the tendon rupture group, again, the management is getting them seen quickly. So this group can go to A&E or be picked up very quickly by the orthopedic team. If it's a full rupture that needs surgery, the faster it's done, the better the outcome. Imaging might include an X-ray, MRI, or an ultrasound scan. If it's non-surgical, then they'll be splinted and put into a brace. Again, this group needs to be seen very, very quickly. So, just look at the time where we are. So, just for the last bit, we're just going to be looking at X-rays, MRIs, and ultrasound scans. In a minute, Mr. Parker will come on and hopefully also talk to us. I spoke to him briefly yesterday, and we just touched on X-rays and how so many people have been X-rayed in a non-weight bearing position. And one of his big hopes from today was making sure that when we are sending people for X-rays, particularly for knee osteoarthritis, that this group are done in a weight bearing position. So if we're looking at fracture, we've already said that X-ray is the first choice, but it's also the first choice for osteoarthritis. When we are sending those patients off on the report, please do put right knee weight bearing X-ray. Sometimes it's not done weight bearing, which will mean that when they go to the consultant, it will be done again. The non-weight bearing X-ray looks very different to a weight bearing X-ray. The other consideration is if we think that the issue could be more patellofemoral, that we also write a patellofemoral skyline view. So for someone that had patellofemoral pain, pain on stair climbing, pain squatting, and it was very much specific to the patella, then we could ask for a full weight bearing knee and a patellofemoral skyline to cover both areas. With arthritis of the knee in the older generation, the X-ray is fine. We don't need an MRI scan. So what often occurs is that we've got a patient with chronic knee pain, X-ray confirms severe degenerative changes, and then they're often referred for an MRI scan. That isn't needed. It's going to be their symptoms, their pain, and the X-ray that would lead them into either an ESP or the orthopedic team to discuss having surgery. Just going back to the X-rays, there was some research this year which looked at non-weight bearing X-rays, and if you don't request it being weight bearing, then 18.5% of patients had to have their MRI repeated in the next 12 months, compared to only 4% had a weight bearing X-ray. So, one, that's a radiation risk to the patient, and secondly, it's a cost and a time restraint. So, making sure we get patients referred for X-rays with a weight bearing status is really vital. MRI scans, now these are great for looking at when we're thinking ligament, if we're thinking meniscus or cartilage damage. They're also really good for looking at people with bone marrow edema. We can also look at them sometimes for people that have a tendon tear or tendon rupture. So MRIs are good for that meniscal group, for the group of patients that we think have had trauma and may have had an ACL or a PCL or a lateral ligament injury. If we look at the ultrasound scan group, we don't generally ultrasound scan knees for arthritis or for ligament problems. We use X-rays and MRI scans. So ultrasound scans are used for lumps and bumps like we always do. They're very good for looking at the vascularization of lumps and bumps that needs to be removed. They can also be quite useful in looking at tendon ruptures or tendon tears if it's not being picked up on an X-ray and an MRI scan, because we have the capacity to do it under movement. So a dynamic ultrasound scan can be really useful. Okay, so that's the presentation to there. I'm hoping that Mr. Parker is available. I don't know.
I'm here.
Hi,
I was
Mr. Parker.
there when you started with X-rays. So, sorry. Hi, Ian. That's
Hi,
good.
Ian. Is it okay for you just to speak for a bit? Is that okay?
Yes, sure. Thank you, everyone. And essentially, if I could share just one screen. You guys able to see my screen?
Yeah.
Ian?
You can see it.
Yeah.
Okay. Hi, everyone. I'm Asif Parker. I'm one of the consultants here. Half of my practice is arthroplasty and other half is actually sports injuries. And the reason I'm sharing this X-ray is this is one of my patients. She came to see me and I did her weight-bearing X-ray. And as you can see, it's bone on bone. And then we discussed the options and she went for non-operative management. For the time being, she was managing okay.
Parker, I don't
A few
think
months later.
X-ray now. Can you show the X-ray again?
It's come off onto yours.
You've got your just
Oops,
general
sorry.
desktop on now. That's great, thanks.
On?
That's it, perfect.
Can you see
That's
that?
it.
Okay, so you probably won't see the dates, but at the right side on the bottom, it's 2020 at Queen's Hospital, which is what I did, weight-bearing X-ray. And then 6 months or 7 months down the line, she had some injury and she presented to King George. And the left side X-ray is 2021. And you can still see the joint space is sort of preserved. Or if I may put it this way, the 2020 look worse than 2021. Clearly, that doesn't make any sense. And that's not possible. So the only difference is weight bearing. And it is important because if you see bone on bone, then that is actually end of treatment from surgical point of view, meaning there's no role for arthroscopy here. This is the disease has gone too far advanced. And then the options are pain management, injections, or joint replacement. And this is one thing I wanted to emphasize really. I know Ian has covered the rest of the topic, but can you see the next slide now?
Yeah.
Yes.
And so there is enough evidence to basically say that non-weight bearing X-rays in any population 40, 50 plus is actually not helpful. And it has huge cost implications because if you see that X-ray where it is bone on bone, there is no role for MRI scan. And we just stop the clock there and then basically make a decision based on patient symptoms. That is one. And second thing is meniscal tear. So it's a very common injury. And if you scan anybody after the age of 50 years, they will have some signal change in their meniscus. But what we need to understand is which meniscus needs treatment. So if you have a patient in absence of arthritis and they have bucket handle meniscal tear, then we repair them. But degenerate meniscal tears, the first line of treatment is usually physiotherapy, symptom management. And this is, can you see this slide now?
Yep.
And this is really what happens. By the time patients comes to surgery, you have narrowed them down. Lifestyle modification, medications, injections, and then there's a small percentage who actually benefit from surgery. So that was it from me. Anything specific you wanted me to add, Ian?
No, it's just whether or not there's anybody else out there that wants to ask you any questions at all or ask me at all. I don't know if anybody's got any questions on the comments. I can't see them at all.
Yes, please. Just anyone, just feel free to ask any questions you want to ask Ian or Ms. Parker, and we can go through that together.
So I've got a question, Mr. Parker. It's Marie Loizides. So I'm just going to ask if there's one thing that you think that you need from your referrers that you don't get already, what would it be, information wise, or change in decision making? So what's the biggest thing that you think would be a quality improvement for your patients?
I couldn't hear you, Marie. I don't know, it's my network or it's...
Did other people hear me?
Heard you yet?
Yeah.
So I was just saying, what's the one thing that you would want from your referrers that would make the biggest quality improvement to the referrals you get through and the biggest improvement to your patients? So what would you want to ask of your referrers to do with your referrals, either information to add on or pathway changes to make?
Marie, I'm really sorry. I missed your first half of question. I don't know. I think I had some network issue.
Okay, I'll put it in the chat.
No, I can hear you now. Sorry.
So can you hear me now?
I can hear you now. Really sorry.
Okay, lovely. So I said, what's the one thing that you'd want us to change as far as your referrals are concerned? So what's the biggest thing that you think would make a difference to the quality of referrals or quality of care that we can give the patient? So if we've got referrers on this call today, what would you like to say to them would help you be able to manage your patients?
Assessing weight-bearing X-rays, because what happens is patients get MRI before X-ray, and then invariably MRI picks up signal change on meniscus, and they see the report or they get told that you have a tear in your meniscus or tear in your cartilage, and they walk into the clinic expecting there is a tear in a cartilage that needs operation. And then you get their weight-bearing X-rays, and basically you have to start from the beginning and get this out of their head that you actually don't need arthroscopy. So unfortunately, I gave a talk to GPs recently, and unfortunately, the system is such that we see a lot of patients, and I'm talking about 50 plus, obviously, clearly young patients, no problem. But anybody, I mean, literature says 40 plus, but I've just pushed that number to 50. Anybody 50 plus should have weight-bearing X-ray first. And it just saves a lot of time, money, effort, headache for both patients and us. Because it becomes difficult if they're coming to your clinic with an expectation of having a keyhole, thinking that will solve the problem, and then you telling them actually keyhole is not going to work for you, it's gone too far.
That's great, thank you.
I think from my point of view also, it's just recognising pathways. So, you know, for an orthopedic consultant, that, you know, it's about conversion from patients probably into surgery, you know. So the more patients we can manage outside, the better. So if we're looking at our ESP services and referring into us, like currently at Porters Avenue, we haven't got a long wait. I think we're 3 to 4 weeks, so it's not too long a wait. And, you know, if you're unsure about a knee, then by referring them on to us, we can assess that patient, we can organise imaging, or we can inject if it requires. And then patients that then are appropriate for surgery, that want surgery, that fit the criteria for surgery, that have had conservative management, can then get referred on, so that conversion would increase. I think the issue is when patients get referred in without having those things in place first. So we've got the FCPs, we've got the ESPs that are good at assessing these. The surgeons want patients that you know, the surgeons want to do surgery. For us, it's about recognising this group and make sure that when they do go, that we've ticked all those boxes and that they're appropriate. And that's going to save a fortune for the NHS.
Absolutely agree. So, yeah, Marie, we looked at my extract. So we've been doing these bones weekend clinics to catch up, and I did 100 patients on a Saturday, and the conversion was approximately 15%. Some of my colleagues did 200 patients, both day Saturday and Sunday, and the conversion was again 15 to 20%. So that is consistent figure, which means if we roll this pathway, then we should be able to tackle that.
Yeah, I completely acknowledge that. I think that one of the things that we have problems, so for those people who don't know me on the call, I work with a single point of access for MSK. And the problem that we have is a lot of the referrals ask for orthopedics for their patients without a clear reason why. And when we speak to the patient and ask them if they're at the point of wanting an operation, a lot of patients say no. They don't realise that going and seeing an orthopaedic consultant actually is going to see a surgeon about surgery. So it's exactly what Ian's been saying. But unfortunately, due to the sheer capacity of referrals coming through, we don't get the opportunity to phone every single patient that's been put down for orthopaedics. We have to make a judgment of the information we have on the form, and we can't always see whether those conversations have been had. So the plan is to change the referral form to a digital form, which will actually be asking those questions of our referrers. So we can see clearly that if a person's put through to see you in orthopaedics, that somebody's had a conversation with them, they've had their conservative measures first, and they are actually surgery ready. So we are working towards improving that in the future.
Can I ask, do you guys have access to X-rays? Can you see images yourself?
Yeah.
And because when I was talking to GPs, I was told that they get the report of X-ray. They don't actually, unfortunately, see the images. And if you can see the images yourself, and then it will be easy for you to see it and also to convince the patient what the problem is.
So I think that when in-health is used, Ian can correct me if I'm wrong, that they will get a report back. So maybe people working in primary care only see a report, but I think you can actually request the image to be able to view the image. But as far as I'm aware, it's not standard for the image to go back.
My understanding is in-health is currently used for MRI, not for X-ray. Is that not the case?
I don't know, Ian?
Yeah.
Do you have in-health x-rays? I think Ian's frozen. Oh no.
Everything is gone.
Ian, do we use in-health for MRI or X-ray as well?
Sam, can you hear us?
Yeah, if I can take myself off mute, I shall be with you. Yeah, so I believe we're currently using them for MRI. You're right.
Yeah.
Okay.
If that turns out to be wrong information, we will share that later. But as far as I'm aware, it's pretty much just MRI.
Marie, hi there. My name is Nathan. I'm just going back to what you stated in regards to being part of SPA. Are you getting referrals simply because patients aren't able to get through to their GPs in this current climate? Are you seeing a lot of that, and so therefore they're just trying to get any form of help, or is it generally they're specifically wanting to go through that route? Just out of curiosity.
Yeah, just to clarify, so UCG have commissioned a single point of access service for all musculoskeletal referrals, and at the moment it's mandated for trauma and orthopedics and all therapies. So when people are referring into physiotherapy or orthopedics or extended scope practitioners, it has to go through single point of access. And it's a way, it's a gateway basically for us to be able to stream the patients to the right service. But obviously we can only do that based on the information given on the referral. And that's our challenge at the moment, is that we don't always have enough information to make
Right. I see. Thank you.
Is there anything that would help you or benefit you if I cover meniscal injuries or sports injuries? Because Ian and I spoke yesterday, and in 30 minutes, there is as much as he can cover with the pathway. Is there anything specific that physiotherapists here locally would want me to focus, and we can always fix a date and arrange a talk whenever it suits everyone online?
Yeah, I think, like personally, I think that would be great. So maybe look at those. I think if you're looking at most of your work, it's going to be either meniscal tears or arthritis. So maybe focusing on those two areas and really trying to highlight the patients that you want to be seeing. I think that would really help.
One more area I've picked up is patella instability, and that I've done about half dozen now surgeries for those, MPFL and transfers for tubercle, and they seem to be doing well. So that's one area I wanted to work with you, because it's, again, half work is surgery, half work is physio, and it's a common condition.
Yeah.
So I think that we have actually got some time now, haven't we, for this session? I don't know, did you want to briefly go through that now?
I can just go through the GP presentation that I did recently, if there's anything. One area, again, it's rare. That's why we don't include this in pathways, because you want to address common things first, is SONG, spontaneous osteonecrosis of the knee. This is typically seen in 50+ age group. Not very common, but they present with constant pain and rest pain. Night pain. You don't get this in early arthritis or meniscal tear pattern. So that is one indication, one and only indication, where in 50, 60+ age group, you would still do an MRI scan. It's called SONK, S-O-N-K, spontaneous osteonecrosis of the knee. But again, that is diagnosis of exclusion rather than first thing in your mind. How much time we have, Marie?
I think until 6. Until 6 p.m.
Really? That's good. Not this one, sorry.
Sorry, we've got to 5:50. That's in 5 minutes because we've got the next. We've got networking session at 6 o'clock.
We've got 5 more minutes.
Yeah, 5 more minutes.
Yeah.
In that case, I was thinking if you have any questions, please ask now and then send me 1 or 2 topics, or I will arrange another date and we can talk about meniscal tear patterns and patella instability. Is that okay?
Fine, yeah, thank you. Just, was there anything from my presentation that anyone wanted to pick up on or discuss? Anything they didn't understand? It's a huge subject, and we can't cover everything. So, you know, the other option that we've talked about is organising eventually when we can either come out or the GPs can come to us, particularly at porters, and we can maybe just, you know, just in small groups assess the knee, look at the knee, and just look at the assessment processes. So with COVID, it's been really difficult. I think that'd be great. We're sort of moving on to get involved with some of the CPD work for the GPs and the first contact physios. So I'll talk to Marie and Sam and see what we can do in the future.
And once these restrictions are over, we can maybe have a face-to-face session, and there are certain clinical tests that clinicians do. There are certain tests that I have picked up from physios, and then it'll be an examination session of the knee injury.
Yeah, I think that'd be really useful. And like Ian says, I think we're fully supportive of sort of lots of shared learning opportunities between all different partners in the area. Yeah.
Okay. All right then. Well, I will say goodbye from me, and we'll leave you to your meeting.
Yes, so goodbye from me too. But yes, take home message from us today is anybody 50 plus, please do weight-bearing X-rays before MRI.
Lovely. Thank you guys for your time.
Take care. Thank you. Bye-bye.
Thank you very much. Bye-bye.
Thank you so much, everybody, for attending. Someone's asked a question about the recording. You'll be able to access the recording tomorrow on the website. So I'll be sending out the PowerPoint presentation as well. Thank you so much, all.
Thank you.
Thank you.
Thanks. Bye-bye.